Welcome back. Hope you had a great break. We're going to jump right into our next session now with Dr. Manu Jain. Dr. Jain is a professor of medicine and pediatrics at Northwestern University's Feinberg School of Medicine. He joined the faculty at Northwestern in 1996 and is now a full professor. Dr. Jain has been the director of the adult CF program at Northwestern since 1997. He's received funding from the NIH, Veterans Administration, and CF Foundation for his investigative-initiated research. He's published over 100 peer-reviewed articles and served on numerous national CF boards and committees. Currently, he's the adult program representative on the CFF's Center Committee and the Planning Committee for the North American Cystic Fibrosis Conference. Today, he will present mRNA therapy for people with cystic fibrosis, next steps. Welcome, Dr. Jain.
Thank you, Jim. It's really a pleasure to be here. So good morning, good afternoon, or good evening, depending on where you are. It really is exciting to be here at this conference. I've attended before in person. It's really, I know, a wonderful conference, and I look forward to bringing you some information about mRNA therapy for CF. Next steps, the possibilities and challenges of mRNA therapy on the horizon for people with CF. So why don't we go ahead and get started? These are my disclosures. So I always like to start about things that might be coming down the line, to look back a little bit. I think it's always instructive to see where we have been in terms of understanding what the next step is going to be. What I'm showing you here is a timeline starting roughly in the late 1930s, when CF was first described by Dorothy Anderson, and following that, about 70, 80 years of benchmarks. And so what I want you to notice is the yellow line, which is the predicted survival for people with CF based on the registry data over the last 40 years or so. And what I want you to note is the continuously upward curve of expected survival over that period of time. And on that, that line, you also see some hallmarks of CF care and delivery over that period of time. A couple of things I'll mention: the sweat test was developed in the late 50s. The CFTR gene was mapped in 1989. And in the blue, you see a lot of the therapies sort of targeting the lungs, but other parts of the body as well, that have been used and developed for the use of people with CF. And then finally, at the very top right, you see all the modulators that have been approved over the last 7 to 10 years that are available now. So this kind of gives you an idea of where we've been, where we are now, and then hopefully I'll show you what the next step should be. Times that definitely are changing. So when we look at modulators, the first one that was approved was Kalydeco. And at that point, when it was approved, about 10% of people with CF were initially eligible. Following Kalydeco, the next drug that was approved was Orkambi, which is a combination of a CFTR corrector and a potentiator. And that was, at that time, applicable to about 50% of people with CF. Following Orkambi, we had Symdeko, which is also a combination of two medications, of a corrector and a potentiator. And about 60% of people became eligible for Symdeko. And then most recently, about 2.5 years ago, Trikafta was approved. And this was two CFTR correctors plus a potentiator. And it was a big jump in the number of people who would be eligible. About 90% of people with CF are eligible for Trikafta, and it's very highly effective. So this sort of pyramid shows how there's been a continually increasing number of people that are eligible for modulators. Now, this is great. However, we still have about 10% of people who, for various reasons, are unable or not eligible for these modulators. And this highlights the work we still have to do going forward. And parenthetically, I'll mention that of the people who are not eligible for modulators or can't use them, they're disproportionately people of color. I'll show that here in a second. So just to go through it in a little bit more detail of which people with CF need additional therapeutic options. Clearly, people whose genotype, their mutations, are not indicated for Trikafta or other modulators. Those people need additional treatment options. There are also people who, for various reasons, may not tolerate modulators. They may have side effects, whether it's skin rash, liver problems, drug-drug interactions, that they may not be able to use modulators. So they clearly need additional treatment options. Now, we always see a spectrum of clinical effects. Some people have had a very, very robust clinical response to Trikafta, but there are a few people who have a relatively modest clinical effect, and they would obviously need additional treatment options. And finally, you can make an argument that even if you've been on Trikafta and have gotten a very good treatment effect, at the end of the day, it is still not a cure. And if our goal is a cure for all people with CF, then an argument can be made that every person with CF needs additional treatment options. Now, if you look at the distribution of people who are ineligible, over the age of 6, ineligible for Trikafta in the CF registry, based on their background, you can see that of people who are of Caucasian background, about 10% or so are ineligible based on what their gene mutations are. But if you look at Blacks or Hispanics, you can see there's a higher percentage of people with that background who are ineligible for Trikafta because their genetic background is different. And so clearly there's a disproportionate need to develop new therapies that can help our Black patients and Hispanic patients. So to move on to the main part of my talk. Now, what's RNA? So RNA is a molecule that sits in the cell. The RNA stands for, it's an acronym for ribonucleic acid. And in some ways, it is similar to what we understand DNA to be. There are 4 nucleotides that are repeating, that are bound together sequentially to create a long RNA molecule. Now, in contrast to DNA, it is a single-stranded molecule as opposed to DNA, which we know is double-stranded, a so-called double helix. Now, there are many different kinds of RNA that you may hear about or read about that exist in the cell. There's mRNAs, which is the one that we're going to look at, which is messenger RNA, and it codes for protein. I'll talk about that here in a second. But there are other kinds of RNAs that you may hear about. The tRNA, which is transferred RNA, which is used to make protein, but doesn't code. There's rRNA, which is ribosomal RNA, which is also important for making a protein, but doesn't code for the protein. And there are other smaller RNAs, which are used for, which are in the cell for various other activities. But for the purposes of our discussion today, we're really going to focus on the mRNA, the messenger RNA. So what does messenger RNA do? Well, I think if we sort of think back a little bit to our biology class in high school and look at this diagram, it'll give you a better idea what the mRNA treatment is supposed to do. So we know our genetic code is in the DNA. The sequence of the DNA is where our genetic code lies. That's where the CFTR gene is. Now, when a cell makes a protein, now the protein is a sort of the workhorse of a cell. That's what does all the functional activity of a cell is dependent on the protein. So the way this works is that the code from the DNA is made into messenger RNA. This process is called transcription. And this mRNA will lead to the production of a protein, in this case, CFTR. So you have DNA made into mRNA. The mRNA goes into the cell cytoplasm to make the protein, where the protein can do the function it's supposed to. And for CFTR, that's to serve as a chloride channel. I'm having I don't know if someone can help me move the slide forward. Let's see. All right, good. So if we think about CFTR as a car, and the CFTR protein is the car, CFTR mutations can be looked at as a car problem. And how can we solve that car problem? So in terms of mRNA therapy, the idea is that by renting a car, in this case mRNA, you can have a temporary access to a car in such that you're able to carry out the normal function, in this case, the normal function of a cell. This is in contrast to gene therapy, where you actually get a new car as opposed to a car rental, which does the function of the car that's not working. And then if you think about gene editing, that's a concept that you actually repair the car that is not functioning. You keep the car, but then it's repaired and begins to function again. But for mRNA, we think about this as a kind of a car rental. So what does that mean? Well, before I get into that, I want to talk about one treatment that's being tested and developed that also works on RNA, but instead of giving you RNA exogenously, in other words, from outside your body, there are treatments that work towards people who have mutations called nonsense suppression. These nonsense mutations are mutations that lead to a truncated mRNA, as shown here. What this means is that the mutation in the cell leads to a premature stop codon. In other words, your cell does not make a normal length mRNA, and as a result, you don't have any protein made, and so that leads to the problems within a cell and for a person. So how can we address that? Well, there are drugs being developed that can actually address this situation where you can make your own mRNA full molecule. What I'm showing you here is a diagram of what happens when somebody has a premature stop codon, or so-called nonsense mutation. And when you have a mutation that ends with an X, like a 542X, that is an example of a mutation that is a premature stop codon. So as you can see here, as the RNA is being translated into a protein, because you have a premature stop codon, the protein that is made is very short and is destroyed within the cell before it actually gets to where it needs to get to in the cell membrane. But there are drugs being developed that allow the binding of the drug allows the premature stop codon to what we call read through. In other words, the mRNA is not truncated, it doesn't stop, it continues to make the protein. And because of these drugs, this allows you to have a normal length mRNA. And as a result, you have a full length protein that is made. And that full length protein then can get to the cell membrane and function in the way it's supposed to as a CFTR chloride channel. Now, this has been tested in the laboratory. And the drug that I'll talk about is ELX-02, which is being developed by a company called Elox Pharmaceuticals. And what I'm going to show you is information from an experiment that the company did testing this idea in a laboratory using cells from a patient who had the G542X mutation. And then what they wanted to see was if these cells in the laboratory were exposed to this ELX-02 compound, could you have increased activity of the chloride channel? And that's shown there in the green. You can see is that the dose of the drug was increased. There was more CFTR activity detected. This meant that the drug was allowing a normal CFTR protein to be made, at least in a small amount. They did a second part of the experiment in which they wanted to see if we add a CFTR potentiator like Kalydeco or VX770 here, which would allow opening and closing of the channel, could you get increased activity? And what they will show, what I'll show you here is in that blue, when they combine ELX-02 with VX770 or Kalydeco, you get increased activity for CFTR. More chloride is allowed to go back and forth through the cell. So this is proof of the idea that you could combine a new drug like ELX-02 with something we already have, Kalydeco, to increase CFTR activity, which was very interesting and exciting. And they've actually done a small study in patients who have these X mutations, and they showed some results at the latter part of last year. It was a small study, a phase 2 study. They had 12 subjects, and of course, with a new medication, we want to make sure it's safe. And encouragingly, they did not see any treatment-related severe adverse events, which is encouraging. And they did see some increase in the sweat chloride. As we know, sweat chloride is a marker of CFTR activity in a patient. And so there was some indication that there was a modest effect on CFTR activity. Excuse me. Now, there is an ongoing study in which patients who are getting ELX-02, they're also now being given Kalydeco to see if there could be increased effectiveness of this approach. And that study is ongoing, and hopefully we'll get some results later this summer, early, maybe by the CF meeting in the fall. We'll see if there was an added effect of giving Kalydeco on top of this drug. So this approach is not giving you messenger RNA, but it's allowing your own cell to make more of your own messenger RNA, and hopefully we'll have some efficacy. So to get to the talking about messenger RNA, in which you are giving wild type CFTR to a person with CF, the idea here is that if you have CF, that your mutation does not allow you to make a normal mRNA molecule. You have a mutant CFTR molecule, as I've showed you where the arrow is. And as a result, you do not have normal CFTR protein made, and you don't have activity that you need, which is chloride movement. So the idea behind mRNA therapy is that we'll bypass the gene and we'll give a wild type, a normal CFTR mRNA. And the idea here is you give this mRNA that will code for a normal protein. Once it gets into the cell, it'll make the CFTR protein, and the protein will then get to the membrane and work as a chloride channel. The neat thing about this idea is that it doesn't really matter what your mutation is. And this is a so-called genotype independent treatment. So when you give normal CFTR to an individual, regardless of their mutation is, if you can make enough protein, you will have efficacy. So in contrast to a modulator, this kind of treatment, if it works, would be applicable for any CF person. So what does this mRNA therapy look like? And I've shown you kind of a conceptualized idea of what this treatment would consist of. On the left is what we call the payload, the messenger RNA, and this is the part of the treatment that actually codes for CFTR. And there are parts of this payload that includes both the mRNA, which is sort of the white bar there, which is the coding part, but then there are other parts of the RNA which are really important to make sure that once the mRNA gets into the cell, that it makes protein in a very efficient way. And so this is sort of called the mRNA payload. And one of the things about mRNA is that it's relatively sensitive to processes within cell. It can be destroyed relatively easily. So it has to be protected when you're nebulizing and giving it to patients. And that's where the second part of this formulation comes in, this vector, which is called a nanoparticle. So the idea is that this nanoparticle, this lipid nanoparticle, creates a shield, and the mRNA is placed within this lipid nanoparticle, so it sits inside it, and the particle is protected, protects the mRNA, and then it's also optimized so that it can be nebulized, so it can be delivered directly into the lungs by a nebulizer, and then once it gets into the lungs, the idea is that the mRNA is safely transmitted into the inside of a cell, where then it can do its activity to create normal CFTR protein. So most of the mRNA treatments that are being developed are using this kind of approach where you have a nanoparticle which carries a CFTR mRNA. So one of the things that we've learned over the last few years is that that to have normal airway function, we have to have a number of different types of cells present. And I've showed you here a few of these cells that we think are important for your lungs and specifically your airways to work normally. So it all starts with a basal cell in the airway, and that's just sort of sits at the bottom part of the airway. And this is the sort of the progenitor cell of the airway. It's the cell that creates the other cells that are the other cells are made from this basal cell. So it's sort of a self-renewing population that allows other cells to be made. Now, what we've learned is that CFTR is made in different proportions in different cells. And it seems to be that secretory cells that make the mucus in our airways seem to have the most amount of CFTR made in the cell. The reason this is important for mRNA therapy is that we want to make sure that when you give mRNA therapy, it gets into the right cell in the right amount. And so one of the things that we're going to have to figure out is that these new drugs that are being developed for mRNA, are they getting into enough? Are they getting it into the cells in enough amount and are they getting into the right cells? In this case, the secretory cells. So this is an important thing that we'll have to figure out as we go forward. So we speak specifically about mRNA therapy. One of the things that we want to assess, obviously, is does the mRNA allow CFTR protein to be made? And as I said earlier, it is something that would work for anyone, regardless of the mutation. And one of the things we do know is that mRNA doesn't last forever in a cell. It may last for a few days to a week or a little bit longer, but it's not forever. So CFTR protein will be made for a limited amount of time. What this means is that for mRNA therapy, it's likely that it'll need to be given periodically to replace the cells that have been lost that actually took the mRNA initially. Now, this mRNA therapy is not delivered normally to the basal stem cells because these cells sit at the bottom of the mucosal layer of the airways, and it's difficult to get the mRNA to those cells. So just to summarize here for a little bit, so we are all on the same page. So for mRNA therapy, every person with CF would potentially be eligible. In terms of the dosing schedule, we do know that mRNA does not exist for a prolonged period of time, so dosing would need to be repeated, perhaps on a weekly basis. It would be nebulized, at least at first, so it would be delivered directly into the lungs using a nebulizer. One of the challenges we'll face is that we have to make sure it gets into the right cell, that CFTR is important to be in the secretory cell, so that's so it's doing the function in the most important cell, and then it is not going to be a permanent solution. It's not a permanent treatment. I mean, in other words, you need to give it periodically. So how does this differ? How does it similar or differ from the modulators that we have available today? Well, in terms of similarities, we're targeting the underlying cause, which is CFTR function. In contrast to CFTR modulator, this is giving mRNA, but both approaches are trying to have CFTR function in a more normal fashion. They're both novel. These are before modulators became available. There's nothing like that existed, and so they're both new novel therapies. And it took a long time to get to Trikafta, and I think it'll take this a similar timeline, although I don't know for sure, but the timeline might be long as well for mRNA therapy to come to our clinic. What are the differences? Well, one is targeting a protein, as I mentioned, which is what modulators do. For mRNA therapy, we're going to target messenger mRNA. The treatment for modulators is oral. For mRNA therapy, it's going to be nebulized, at least initially. Modulators can target CFTR mutations in the whole body. At least for mRNA therapy, the initial treatment will be targeting the lungs. And then in terms of development programs, the modulators went through a normal phase 1, phase 2, phase 3 with relatively large number of patients enrolled in trials. In terms of mRNA therapy, there are a relatively few number of people with CF who would be initially eligible for this. And so the study designs are going to be a little bit novel, and those are still being developed at this point. But just to highlight the idea that the study designs and the development program might be a little bit different. So as we think about these treatments, what information do we need to have before we feel it's safe to try it in people with CF? That sort of highlighted a couple of things that I think was really important for us to understand before we do any studies with patients. So first thing we want to know is the mRNA therapy that we're going to want to try, is it safe? And so there are lots of experiments that are done in mice to see whether it causes any sort of local, meaning toxicity to the lung, or any systemic toxicity to the body when we give this therapy to mice. One of the specific things that we worry about mRNA therapy is will your body have an immune response? In other words, you are going to make a protein that your body has never seen before, which is normal CFTR. Will you have any response? As we know, we've an era of mRNA vaccines for COVID, and the idea there was you wanted to induce an immune response. because that's how you fight the infection. In this situation, we do not want an immune response because we want CFTR to be produced and be active and not destroyed. And so one of the things we need to look at is whether we can develop it in a way that your body doesn't cause a significant immune response. So these are some ideas behind how we need to judge safety for this treatment. But in the second part of this is it effective? Now, does it actually show that it might be able to get CFTR function at least in the cells or in animals? So in CF cells, we can either look at cells we get from a patient, or there are this new technology called organoids, in which you can take cells from a patient and create a sort of a circular organ which expresses the CFTR, mutated CFTR. And then you can expose either the cells or the organoid to this mRNA treatment, and then see whether CFTR protein is made, either through looking, sort of doing a functional assay to see if chloride moves across the cell membrane, or to see if these organoids swell up as a sign that the CFTR function is occurring. And then if you want to do experiments in an animal model of CF to have further proof, there are things that you would do. There are animal models of CF, that include sheep and pigs and ferrets, and you could test this treatment in those animal models potentially to see if you're able to reverse some of the CF-related changes we see in those lungs when you treat with mRNA therapy. So this is sort of a conceptualized idea of what we need to see before we would want to necessarily go to human studies. Whether we can do all of that will remain to be seen. So what are the active programs that are in development for CF? Well, I've listed on the right the mRNA lipid nanoparticle programs that are pretty close to coming to the clinic. Those are the three companies that are probably the closest. Everybody should recognize Vertex, I would guess. But then Recode and Arcturus are two other companies that this mRNA LNP molecules, and so they're probably closest to clinical testing. Now, we have done some mRNA studies in the past. Some of you may remember ProQR from a few years ago. This was an RNA editing technology, and Translate Bio did a study a couple of years ago of their mRNA, and I'll talk about those in a few minutes here as well. But the ones that are coming down the pike are Arcturus, Recode, and Vertex. So just to show you go back to this concept of, can we actually see evidence of CFTR function in the laboratory before we start testing this medication in patients? What I'm showing you here is an experiment that was done in cells that were collected from a patient with a mutation. And the idea here was that if this mRNA is able to make CFTR protein, you would see an increase in chloride activity, and you would see that as a rise in that curve. And so what I want you to first look at is the VX770. This particular cell had a G551D mutation, and we know this mutation responds to Kalydeco or VX770. The reason they use this cell mutation is because then they wanted to compare how well the mRNA worked relative to a drug we know works in this mutation, which is Kalydeco. And you can see with Kalydeco, you had a nice response with chloride function. But encouragingly, when you saw this lunar HCFTR, which is the mRNA treatment, when you gave 50 micrograms of treatment, you saw almost virtually the same amount of CFTR activity as you saw with VX770. But then if you give a higher dose in the blue, you saw that the activity in CFTR was even greater than what you were able to see with Kalydeco. So this is kind of a proof of principle that if you give these cells this mRNA treatment, you actually can rescue CFTR function, which is very encouraging. Now, what about in animal experiments? What kind of things would we want to see to indicate that the mRNA is working? And in a animal model, what you want to see is that some of the normal abnormalities of physiology that we see in a CF animal model, can you reverse some of that when you treat with mRNA? So there are two kinds of things you look at. The first is to see, well, if I give an mRNA treatment to an animal, can I actually see a CFTR protein being made? And on my slide on the left, The parenthetically, this is an idealized experiment. This is not based on any studies that have been published so far or shown. This is what we'd want to see if this was going to work. So on the left, you would see every area that's brown is where CFTR protein is being made. So this would be an indication that the mRNA was taken into all these cells and the protein was being made, and we can detect that protein using this a staining technique where it's brown. And in terms of efficacy, whether the protein, once it's there, is it being functional, you want to see something like you see on the two slides on the right. So what I'm showing you is on the top is the airway and then a submucosal gland. You can see they're obstructed by mucus and inflammatory cells and bacteria. And if you have mRNA treatment that works, you would see this obstruction is ameliorated. Now you can have open airways. The submucosal glands are not obstructed and they can function in normal fashion. So this it would be an experiment where we would see, oh yes, the protein is being made and it's actually functional. It's reversing some of the physiology we see in CF. So this is the kind of thing we want to look for. I'm going to skip that slide. And then, in terms of understanding what we've seen so far from the sponsors that are developing these mRNA treatment, I'm showing you that here. And so in terms of Arcturus, unfortunately, we have not seen any publicly available information in terms of its toxicity or antibody formation. So this is something that's probably going to need to be looked at before we can start our clinical trials. In terms of efficacy, or I'm sorry, in terms of antibody formation, again, we have not seen any publicly available information. So there's a relative dearth of information at this point, at least publicly available, that we've been able to see. In terms of efficacy, now both Arcturus and Recode have shown data in a public setting that shows that they're able to reverse CFTR function using their mRNA treatment, at least in cells. In terms of animal models, we have not seen any data from Arcturus, Recode, or Vertex with respect to reversing CFTR function. So this is the state of information as we have it today, but I expect this to change over the next few weeks to months as these trials come to our clinics. Just to highlight the past trials that have been done, just to make the point that this type of approach seems to be pretty safe. ProQR was a study that was done about 5 or 6 years ago, where the idea was that you gave treatment to CF patients, and the treatment would allow the RNA, the mutant RNA, to be edited in a way that was now a normal RNA. And it was a nebulized treatment. The main thing that we learned from that study, that giving this kind of treatment was safe. There were no real serious adverse events related to giving this kind of treatment. And more recently, Translated Bio did an mRNA therapy, messenger RNA, using a lipid nanoparticle similar to what I've talked about today. Again, it was a nebulized therapy. And the thing we learned from that particular study, that it was safe, it was well tolerated. There were no severe adverse events that led to people having to stop the treatment. We did not see a big change in FEV1. So the thing we did learn, that this kind of treatment is safe to give to people. So that was encouraging. So there are a couple of challenges we should probably talk about in terms of doing not just mRNA therapy, but any kind of therapy for genetic therapy or whatever. Now, what we do know is that CF airways are not really hospitable to mRNA. They tend to be sticky and thick and acidic. And one of the challenges is to design this lipid nanoparticle that it doesn't get destroyed by this mucus. We also know that immune cells can take up and destroy mRNA or gene therapy, so this has to be resilient for that. Lung cells are continually replaced, and we've talked about how we will probably likely need to give this treatment at a regular period. Basal stem cells are hard to get to because they sit at the bottom of the airway and hard to reach. So at least for mRNA therapy, we're going to have to target secretory cells and ciliated cells. And the CFTR gene is large, and so it does require some challenges with respect to creating the right kind of vector and molecule to be able to get into the airway. So these are all challenges that we've overcome to a degree and will continue to need to work on. As I get to the end of my talk, I just want to highlight some of the therapy, some of the challenges we're going to have with respect to actually doing the clinical trials in patients. Now, I already talked about demonstrating the preclinical efficacy, what we need to see both in cells and in animal models. This is a treatment that's going to be for the long term. And so we're going to need to understand what is the long-term safety of using mRNA-based treatments. Are there targets, so-called off-target effects? Is there an impact of concomitant medications that may need to be given as well? In contrast, a lot of other new treatments that are developed, the first treatment for for mRNA therapy will be done in CF patients. In other contexts, the first treatments are done in human volunteers because we want to make sure it's safe before we give it to people with CF. But because of the specific challenges around genetic therapies and mRNA, the first studies will be done in CF patients. The eligible population will be small. We talked about 10% of people being eligible for this treatment, at least initially. So the pool that we recruit from will be a small pool, and it'll require a lot of cooperation across CF centers so we recruit effectively enough that we learn whether these drugs work or not. And one of the unique aspects of this is does participating in one study, does that impact your ability to study in the future a different kind of study? If you have some sort of an immune response, does that affect your ability to do future studies? It's an unanswered question, but something that we are going to look at very closely and try to understand better. So I just want to wrap up by just highlighting how long it took the CFTR modulator program to come to fruition. Ivacaftor, Kalydeco was first approved in 2012, and it took many years, 8 years before it became approved for our very young patients. Similarly, Trikafta, the ELX-TEZ-IVA was approved in 2019, and it's still, studies are ongoing and looking at very young patients, 2 to 5 and 1 to 2. This just highlights that it takes a long time to develop novel therapies like this. And we're probably going to see a similar kind of timeline with respect to modulators that we saw. I think that's probably going to apply to these mRNA therapies as well. So I think we're going to, we want to be safe, we want to take our time, but the work is ongoing, it's going to continue. And I'm hopeful that we'll eventually be able to have treatments, offer treatments to every person with CF. So I know I may have gone a little bit over my time. I'm sorry about that, but I want to thank you for your attention. I'd be very happy to answer any questions. Thank you.
Dr. Jain, thank you for a fascinating presentation and just such clarity. I just say personally, how much do I love that metaphor with cars? Repair versus rent versus own. That was great. But thank you. And we do have a lot of questions for you. So we'll just see how quickly we can go through this. Starting with the top, is the ELX-02, if I'm pronouncing that correctly, going to phase 3 trials? The plan is to go to phase 3, but I think they're waiting to see what happens with the addition of Kalydeco and seeing whether they will do it by itself or with a combination. So the plan is to take it to phase 3, yes. And people can track this through the clinicaltrials.gov?
Yes, and then the CFF.org as well.
And I want to remind everybody, ELOX actually is here as an exhibitor, so go to their booth and find out all their information. Next question, would post-transplant individuals be eligible to benefit from RNA therapy?
So when you get a lung transplant, the CFTR function is normal in the transplanted lungs. And so at least initially, the treatment for mRNA is going to target the lungs. So it would probably not be indicated for people who've had a transplanted lung already.
How would mRNA treatment work in patients on Trikafta? Can you take both?
So that's an interesting question.
So conceptually, Trikafta works on mutant protein, but it probably also works on normal protein too. And so conceptually, you could take people on Trikafta, give them RNA that would make extra CFTR protein. Perhaps Trikafta could work on the protein that's made by the mRNA, so it could potentially have an additive effect to Trikafta. So conceptually, yes. And this goes back to my idea that, or not my idea, but the idea that potentially every person could be a candidate for this, whether you're on a modulator or not. But the initial studies will probably be looking at people who are not on a modulator because we want to make sure they have access, and they're most likely to show an effect because they have no CFTR function. And we want to see if that has an effect. If you're already on Trikafta, your ability to respond may be smaller than if you're not on anything. So we want to probably do those people first.
Got it. And somebody wanted to know if ELOX is going to be looking at adding Trikafta instead of the Kalydeco.
That's not that I have anything. I don't know that. I've not heard that. I think conceptually, it may make sense to do it. But I think the initial plan is to do Kalydeco, because the idea behind using Kalydeco is that they're really trying to target the potentiator function, the opening and chloride channel once it gets to the membrane.
Someone wants to know, is there a way that mRNA could go straight to the sinuses for those of us post-transplant, or straight to certain GI areas?
Potentially, yes. I think that the idea there would be to expose a cell, whether it's the GI tract or the sinuses. It would just be creating the right delivery vehicle. But conceptually, if you can get the vector and the mRNA to a different cell type, yes, potentially you could get sinus activity and GI activity potentially as well. Although it may be a little bit harder to get to like the pancreas or the liver, because those are a little harder to target by nebulization or directly.
There were jokes in the chat box about mRNA colonics, but we won't go there. Would it be Would this be practically applicable for patients who don't live near medical centers offering this treatment? I know some people have to block out a whole weekend to go to clinic. Does this make sense to have treatments that people need to go in on a weekly basis?
Well, so the idea is that, the trials you'll have to obviously go to a center to get the medication. We have to make sure it's safe. So we need to be able to assess that and make sure everyone stays safe. But, if it gets developed, the idea is not to have to come back to clinic for each treatment. Now, there are challenges around keeping mRNA cold. I think some of you may remember when the vaccine was being developed, it had to be at -20. That limited some of the distribution around it. So these are things that people are thinking about and trying to overcome. But the idea is that it would be a home treatment if it gets developed and approved.
Would there be concerns of doing this therapy with other people nearby, like siblings or friends, from breathing in this mRNA?
Yeah, when we do a study, we're very careful about not exposing anybody else because we don't know the risk benefit. From a conceptual perspective, I wouldn't expect, because if your sibling does not have CF, they are making CFTR protein normally. And so their body's been exposed to CFTR protein. So I wouldn't expect an issue of an immune response to something like this. Now, if you nebulize something, there's always the risk that you could maybe get some, irritation of the airway or something. But in terms of specific issues with immune response, I wouldn't expect to see that.
Is there a difference in mRNA response for people with CF that are older and have damage, lung damage, versus those that are younger? Are older damaged cells less receptive to mRNA?
That's a very interesting question. We don't know the answer to that. The people are older and with more damaged airways, they tend to have more mucus, more inflammatory cells, and it may, that may be more of the issue than actually the mRNA getting into the cell. Once it gets into the cell, the effect may be very similar in a young person versus an older person. But if you have a very damaged lung, it may be harder. It may not be as efficient in terms of navigating all that mucus, inflammatory cells to get into the cell, which is where we wanted to get to. But we just don't know because those kind of studies have not been done.
Somebody had a question about, the CF animals, the ferrets, the mice, the pigs, and are they bred with CF for these experiments?
Yeah, So they have the mutations, not all of them, but some of the more common ones, and they tend to get some of the same kinds of lung manifestations that we see with our patients. And so, conceptually, it's very nice to be able to test this in a before we give it to patients, obviously. But these are very, very difficult animals. Only certain labs, very specialized labs in the country, have the ability to do these kinds of experiments. So there is sort of a limitation how much or how quickly this can be done. So it's conceptually very, very nice and very important, but from a practical perspective, it's not easily done. And these are mostly academic labs that have the ability to do these kinds of experiments.
And a question, do these studies that are going on address missense mutations as well?
So as I mentioned earlier, the really nice thing about mRNA therapy is that it doesn't matter what your mutation is. So that's really important to understand that, whether you're nonsense or missense, you have deletions, whatever your mutation is, if you can get the mRNA into the cell and it makes normal protein, it'll reverse the underlying abnormality in the cell. So it's applicable to everyone.
And you and I'm trying to think, maybe Dr. McCrae had referenced about the issue with basal cells. And the question is, where do you obtain those? Is there some kind of bank? Where do you collect those cells?
Well, the basal cells are produced within your own lung. Okay, I mean, they probably get into that airway when you're an embryo. And so the nice thing about these cells are they're programmed in a way to be self-perpetuating. So every time a cell divides, one of them becomes one of these other cells, and one of them stays a basal cell. So it continues, it's a self-renewing population. So this is something that your own body makes, and that allows sort of a pool from which all the other cells come from. So in some ways, if you're going to have a gene therapy approach, this is not my topic, but a gene therapy approach, if you get into the basal cell and it takes hold, then that might be a permanent solution, because then it's in the cell that's going to just continually perpetuate, and then it'll just continue to make the normal CFTR protein.
So that's down the road, how to access those cells.
Yes, exactly.
I want to make sure I got everybody's questions. You were amazing in your rapid response to many questions. Dr. Jain, it is always a pleasure and an honor to have you present with us. We're so grateful to you for sharing your time and your expertise. And thank you for all you do for the CF community.
Oh, thank you very much. I really enjoy working with you guys, and thank you for the invitation. It's really an honor. Take care.